Good morning, everyone, and good afternoon, good evening. I'm not sure where you're watching me from, but wherever you're watching me from, I bring you greetings. My name is Dr. Pascal Randolph Ozewen. I'm originally from Benin. Now, Benin isn't just is in West Africa. It's a country that is in between Ghana and Togo and Nigeria. I am a medical doctor and I'm residing here in Australia, and to be precise, in Sydney. Which makes me one of the hundreds of international medical graduate residing here uh, in Australia. I have already clear, for you to be able to actually be here as a doctor, you have to clear your the AMC Part 1, which is already cleared, then the AMC Part 2, which I also cleared. Now I'm here to just making this video to kind of give you some kind of understanding about the AMC Part 2. If you're watching me now and you probably have already passed your AMC Part 1, and you have started the journey to get into the medical field, trying your AMC Part 2, the clinical, meaning the MCAT, and you've been trying it now for many years, unsuccessfully. Some of you tired of it, some of you discouraged, some of you giving up. I'm here to just call you back into your calling. See, your destiny is to work in the medical field, and that's why you're here in Australia, or you are from outside of Australia and you are hoping that you will clear this obstacle and then make your way here in Australia in order to continue practicing medicine. Now, I will agree with you, okay? I will agree with you that this exam arguably is the most difficult entry exam in the entire world. When you compare it to different entry exams, you might agree with me that no, it's difficult. And I'm here to kind of help you to regain again your confidence and to regain again your regain again your calling, to knowing that no, I'm not giving up. I'm going to come back and I will do it. Now, if you compare it to the Medical Council of Canada qualifying examination, MCCQE, it's challenging because MCCQE has got a clear books that you can follow. Let's say you have a clear guidance. But why, for example, here in Australia, what you're given is just the blue book, the clinical book that what you're given and it has got 100 and few hundred questions where the clinical scenario that you go through. But it's you agree with me now. Just by reading that book is not enough. That's why it's a bit complicated. It's a bit difficult. If you compare it to the United States Medical Licensing Exam, USMLE is at another level. Now, USMLE has got a very also clear instruction and a clear books that you go through. But here you have only one book. Now, you compare it again to the Professional and Linguistic Assessment Board, PLAB, in Great Britain, you will again agree with me. No, this is a bit, this clinical exam here, MCAT in Australia, is actually at the net level. You go back now, you go into the New Zealand registration examination again. It's just difficult, to kind of compare those. And the questions that people ask me now, by the way, I've been helping hundreds of IMGs, international medical graduate, to get their feet in here, in the clinical, go to the clinical exam and then get their feet into the medical field. So everything I'm talking about is coming from the place of experience, not just observation and not just guessing. It's coming from a place of experience. Now, I've been asking myself, how come it's so difficult? Why is it that it's so difficult to get past this obstacle? Now, I can tell you the most important reason why it's difficult is because we do not have insights, lack of insights. Now, when I say lack of insight, what I mean by that is the capacity to gain an accurate knowledge, understanding, and wisdom that we needed to apply for MCAT. Okay, we don't have that. We have no idea what it is that they are expecting from us. We don't know what it is that we need to study. We just graduated from wherever we're coming from. In fact, we are not even graduated. I mean, we are more like, we are already working in our field. Some of us, we are very far in our specialty, and we're coming down here and we are told, you know what, you need to sit to the exam. Okay. The thing is that number one is that the MCAT, the clinical exam has got a very specific aim. All the scenario that they're asking you to do has got a very specific aim. And that aim is mainly driving around the predominant assessment area. See, it's mainly focusing on one predominant assessment area. Just think about, for example, you being a doctor, you are like in your office, and a patient comes to you. You take history, right? Then you might do physical examination. You might even do like investigations. That will lead you now to make the decision. What is it that the patient is suffering from, right? Now, they are going to be assessing you in one predominant area in your clinical exam. And if you don't know that and you're just talking, you might miss the point. The second thing is that it has got a clear format. 2 minutes reading, we know that. Even though we don't know exactly what it is that we should be focusing on while we are reading the 2 minutes. What should I do during the 2 minutes? It is something that I'll be talking to you about just in a while. And you have 8 minutes of performance where you assess your attitudes. The way you handling the patient is assessed during those 8 minutes. Number 3, one of the things that is expected from you is that expecting for you to carry yourself in a certain way. There is a very specific way that you should carry yourself throughout that given scenario. And they will be assessing that. They will be checking that. So we don't have insight into what is expected of us. We don't have insight to that. And of course, we also don't have insight only to how do they actually mark me after I've gone there. I did, for example, the 8 minutes scenario, and then how do they actually mark me? Now, the marking is divided into 3. You have what is called the key steps. I will be explaining just in a while what does that mean. And then the domain, the very specific domain in which they are assessing you. And of course, overall impression of the candidate, meaning overall impression that I have about you as an examiner. Okay? And finally, I'm expecting you to behave as a doctor in Australia. And what does that mean to behave as a doctor in Australia? There is, I will talk about that just in a while. So in summary is that this exam is very difficult because we don't have insight into what is the aim of the exam, insight into what is the format of the exam, the true format of the exam, insight into what are the expectations that they require from me, and what is the marking criteria, and of course, how do they expect me to carry myself here in Australia as a doctor? Okay. Let me take you through quickly through the aim again, talk a little bit about the aim. Now, the MCAT is designed for testing your clinical skills. When I say MCAT, what I mean by that is the AMC Part 2, I'm assessing your clinical skills. I am not assessing your knowledge. MCQ has already done that. I am also not assessing your fitness for task assessment of an applicant's skill, knowledge, and experience on the nominated position in specific location. I'm not assessing your fitness for a nominated position in a specific location. That one is done by what is called PESCI. Okay, it's not PESCI. It is MCAT. Again, I'm not assessing your English language. English language will be assessed by OET, IELTS, PTE, and TOEFL. So, clinical skills. Now, clinical skills is also called experiential knowledge. Okay, experiential knowledge. The knowledge that is acquired through practicing, that is what is assessed. Now, of course, that to assess that knowledge, I will set you up, for example, in a scenario where a medical scenario or mental scenario. Okay, now I will use, for example, short or long mini clinicals, observe cases, and create the cases, and then just assess how you will carry yourself. Okay, so it's not so much about what you know. I'm not focusing on what you know, but what I'm focusing on is how do you use what you know? How do you use what you know? How do you apply what you know? Application of knowledge rather than knowledge. you know, yeah, so that's it make it a bit interesting, So if you look at, for example, MCQ, which we done before, I'm just assessing what your factual knowledge. It is not experiential knowledge, just factual knowledge, which has already been done. Okay. The failure rate is extremely high. I said it before, and I will repeat it again. I'm not scaring you. I'm just stating the facts. The failure rate is higher compared to all the entry exams all over the world. Okay. Now, the reason why I say the failure rate is higher, we've already talked about it, because we don't have insight, right? We talked about it already, and I'm not going to go back again to it. Now, what is then expected of me as MCAT candidate? Here I am. I've already passed my MCQ part, MCQ, meaning AMC part 1. I'm now embarking in the project of passing my clinical exam. What is expected of me? If I know what is expected of me, then I will prepare my exam based on what is expected of me, right? What is expected of me? Number one, you are expected to have already attained cognitive factual knowledge. And that is done by MCQ, right? So MCQ is already kind of, you pass on MCQ, so that means that you are now eligible to start to come now and do your clinical exam. So I'm assuming that you already passed your MCQ, meaning that you have already attained cognitive factual knowledge of medicine as it is practiced here in Australia. Number two, I'm expecting that you do have clinical skills, meaning experiential knowledge. I'm expecting that you know how to carry yourself. You have medical, you have like experiential knowledge. Number three, I'm expecting that you do have what is called Australian professionalism. What does that mean, Australian professionalism? What is that big name? It's just simply mean, how do you carry yourself through a given clinical consultation scenario? I'm expecting that you do know that there is a way that I'm expecting you to carry yourself as you go through one scenario to another. Number four, I'm expecting that you do know that your position is newly qualified graduate, meaning PGY1. Now, the truth is that none of us IMGs are considered PGY1. You know what does that mean? I just finished my degree. I haven't even done internship. Okay, I haven't done any internship yet. Okay, that's what PGY1 is all about. So PGY1, someone who has just finished his medical degree and hasn't done internship, doesn't know much. But all of us, we are really far in our specialty. We are far in whatever it is that we've been doing before moving here in Australia. And they are suspecting us now to behave as someone who just graduated. You know what does that mean? They're expecting you to keep it super simple. Now, and if you allow me to use the word stupid, Allow you to be the one stupid. I mean, that's they're expecting you to keep it super simple and stupid. It just simply means that you don't make things too complicated, but at the same time you don't make it too simple. Do you see, for example, the reason why we fell in? That's the reason why we fell. If I don't know that, I will just come in. For example, for me, I'm a general surgeon. I did my fellowship in general surgery, so I do have a huge amount of knowledge in general surgery. If I come down here and doing, for example, this exam, and I begin now to carry myself as a surgeon in any given scenario, that is already a fail. If I start talking and then taking it to a higher level, for example, I'm in trouble already. Okay, these are the things that are expecting from you. So what should I do? I'm sure the first question that you probably ask me say, now, Dr. Pascal, you've been here for so many years. You should have some kind of experiences. Can you please tell us what should we do? We don't want to waste our time. We are like fathers, we are mothers, we are, we have our responsibilities. We have kind of commitment to do. We have and we can't just, we can't afford to waste time. So what should we do? I'm here for that. I'm here to answer that questions. Okay, what should we do? Now I'm going to be giving you, it's going to be very simple. You just need to do three things for me. Only three things, and you are ready to clear your exam. Just three things. Number one is what I call the three REs solution. RE is what I mean by RE is repeated, RE repeated exposure. You need repeated quality exposure. What I mean by that is that you join this clinical bridging courses, you do OSCE, and then now you begin now to have study partners. Now, multiple partners is very important because one partner might help you to do better in physical examination. One other partner might help you to do better in pediatrics, obscene gyne, psychiatry, etc. Okay, so you need multiple partners. Now, the moment when you begin now to expose yourself to a clinical bridging course, even what I'm doing now, that's considered exposure. I mean, get to understand, get to know. You can't sit down behind your screen, looking at your computer and expecting that as you reading, everything will be fine. No, 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 no. It's not going to work that way. Now, for your MCQ, it's fine. You could sit down behind your computer and just doing questions. But this one here, now, you need to get out there. You need to get and join a clinical bridging course or ski study partners that you put together and then start now to expose yourself into what it is that they're expecting you to do. Remember, when you begin to expose yourself in a very repeated way, so what's going to happen? Your brain will begin now to register. Your brain will begin to register whatever is it that you have been exposed to. And you will acquire what I call experiential knowledge, which is what is required for you to clear the exam. Now, when you acquire that kind of experiential knowledge as a result of repeated exposure, then now you can now recall. What I mean recall is you apply now, and that is a good performance. You see, so that's easy. Three R's, simple. One, repeated exposure, repeated quality exposure. As you expose yourself to whatever is it that you want to register, your brain will begin to register, then you can apply. Now, in another word, there is no way you will have good performance until you have reached your experiential knowledge. And there's no way you will reach experiential knowledge until you've been repeated exposed to whatever is it that you want to get experiential knowledge from. Does that make sense? So that is it. Those are the three R's. Okay. Now, but I'm not going to leave you just there. I'm going to take you another level further. Now, so just kind of talk a little bit about in year exposure that you're having together with me. Now, I'm talking a little bit about the multidisciplinary clinical assessment as MCAT, some kind of, how does it look like? When I go there, how does it look like? Now, you probably know already, it's 20 stations altogether, right? 20 stations altogether. You have 4 stations, rests, and 16 stations scenario. Now, within those 16 stations, you will have like a 14 station that's going to be marked and 2 that are going to be, they're not going to be scored. Okay? So, 16 station, marked. 16 session, 14 will be marked, will be scored, and 2 will just be like pilots. Among those 14, you just need to pass 9. That's a good news. Now, before it used to be 11, it used to be 10, but now it's 9. You just passed 9, and that's it. You passed 9, and you qualify to apply for jobs and get your job and start working now on the supervision, right? Now, those 16 sessions that you're going to be going through, so each station will last 8 minutes. When you enter 8 minutes, we know that already. So at the stations that got the more numerous multiple tasks that you'll be asked. Now, the stations are highly focused, so focused that it's almost, allow me to use the word mechanical. It's just rigid, clear, very focused, and the candidates are given very specific instruction. You must follow the instruction. Of course, now it says a preset structure mark scheme is used. So the examiner has got something in front of him. Usually be kind of an iPad, and everything is written in there, and you just need to get in and get out according to the formats and according to the pathway that's kind of pre-established for you there. Okay. Now, the emphasis during the whole thing is mainly what you can do rather than what you know. So I'm not really, I'm not really impressed by what you know. The quantity of your knowledge does not really impress me. What actually impressed me is mainly what you can do during that given scenario. The application of knowledge rather than the recall of knowledge. If you sit down there, you start recalling knowledge, I will know, and I'm gonna mark you down, and that will be very difficult for you. So it's mainly the application of what you already know, rather than recalling knowledge. Now, okay. As you go into each scenario, as you go into the exam, you are going to be encountering 6 different types of scenario. Just give me a second. Okay, you are going to be encountering 6 types of scenarios. Okay, 6. Now, this is based on the predominant assessment area. Okay, remember I told you before that they're assessing you in a very specific area. The domain, very specific area. And based on that specific assessment area, you're going to be encountering 6 different scenarios. Scenario number 1. History taken. Now, at this stage, what I'm assessing is just your ability to take and organize good history. I don't care about you arriving at destination. I don't care about that. It doesn't matter whether you are landing. Now, but I would just be assessing how you're flying. I don't care whether you are landing. Okay? It's more like, can you keep that airplane in the air for me stable? I'm not talking about landing. Now, you agree with me, for example, if, for example, you were like, I don't know, I'm not, I'm not a pilot, but I will assume that for all pilots, they will need to understand 3 stages. 1 is to take off, right? You take off, right? Stay there in the air and then landing, right? Take off, stay there and landing, right? So for this exam here, when you take off, you're taking off. That means that you are in the clinical exam room. Stay there in the air. That's what I'm not expecting. I don't know. I'm not assessing you landing. So the landing is actually the diagnosis. Okay. Now staying out there is actually the history. You take the history and don't jump quickly in there. So you will assume, for example, if, for example, you are a pilot and you worry about how to land while you are there in the air, then that's a problem, right? You just stay out there in the air. So for history, I'm assessing your ability to take a history from a patient that's come to you, but do it in a very organized and systematic way. That is scenario number 1. Scenario number 2, I would just be assessing your ability to perform a physical examination. I'm assuming that you have done your history, and then now I just, you know what, this patient is coming to you. Can you please conduct a physical examination? So in this case, now I will be assessing your professionalism. I will be assessing your organization. I will be assessing your techniques that you are using. I will be assessing the accuracy of that technique. And finally, I will be checking now my impression of you. You see, so that is examination. So physical examination, it could be medical physical examination or mental state examination, by which you do your aseptic J's and you go through your aseptic J properly, and then now kind of give it to me. Now, the third one will be mainly diagnostic and formulation. Now I'm assessing your landing. now talking about the what I just gave before, the pilot. I said pilot, you need to know how to take off to stay in the air and landing. Now I'm assessing now, are you landing properly? Landing, diagnosis, formulation. You give me the diagnosis and the differential diagnosis with reasons. Number 4, investigations, interpretation. Now, in this case, now, you know what? The patient came to you, when the patient came to you, did your physical examination, you did your history and all the thing, and then you did investigations. The investigation result is here, and I'm assessing your ability to actually communicate to the patient. Now, this is what I call communicating. Communication is based on one person who is sending a message and a receiver who is receiving the message. Whether you have communicated properly, it will depend on the fact it will depend on whether the message is being received by the receiver. It's not about just you talking, right? So the investigation interpretation, you will have to use what I call, this kind of a format that I call, it's just spikes. We'll talk about that just in a while, spikes. So spikes just simply mean that you set in yourself, set in the room, set in the patient, and then now check the patient perception, inviting the patient, breaking down the knowledge, and then listen to the patient emotion for E, and then now you tell the patient what is your strategy. Number 5 now will be management. Management, counseling, education. Management is what is done after the doctor has taken history and physical examination conducted already. What does he do next? That is management. You don't just talk about treatment right after that. You tell patient what is the diagnosis in jargon. You explain to patient what is diagnosis. You tell patient what is now the implication now that the patient is sick. You tell patient what are you going to be doing right now, your long-term management, and now you talk about now the review, red flag, reading materials, and then etc. All the R's, right? Number 6, integrated diagnosis management. Now, this one here is when diagnosis plan and management go together. Now, this one is mainly in life-threatening scenario. Did you see now? Have you ever known that before? Did you know that you're going to be encountering 6 types of scenario every time you go to your clinical exam, and that those 6 types of scenario, it depends on the predominant assessment area. That sometimes I might be assessing you just on your way of taking history, your ability to take history. I might be assessing you just on physical examination. I might be assessing you on you landing diagnosis and formulation. I might be assessing you on investigations, interpretation, or just management counseling, or just integrated diagnosis and management together, which is life-threatening situation. Now, you see, the way you behave in a history taken is completely different from the way you will do it in an examination, diagnosis, investigation. They are different. Guys, if you're not clear about what type of scenario is it, you are already dancing to wrong music. Okay? You're already dancing, and your dance doesn't go together with the music that's being played. Okay? Now, because of that, you will have to keep in your mind, for example, so what do I do if, for example, if it's adult men's health? So you coming down there, you should be asking yourself, if this one is adult men's health, you have to have like a format that you use in taking history. For example, adult men's health. In a history taken, for example, I will suggest 3 P's AR approach. What is 3 P AR approach? P stands for place, the place. Where you are, who are you, and the task that they're asking you to do. Remember, where you are and who you are and the task that you are asked to do will affect the way you carry yourself. If you don't know where you are you in GP, are you in a hospital? And even in a hospital, are you in ED? Are you in the ward? If you are not clear about that, then it will affect your behavior, right? If you don't know who you are you a SRMO? Are you a junior medical officer? Are you a senior resident medical officer? Are you just a resident medical officer? Now, if you don't know that thing, then it's a bit, you're already on your way to the wrong direction. If you're not clear the task that you're asked to do, then you might do something wrong, right? So, and of course, now from there, you go on to the second P, which is professionalism. You're building rapport with the patient, making sure that the patient is connected with you, because everything that you're looking for is coming from the patient. So therefore, if you don't set the patient properly and kind of build a good rapport with the patient, chances are that you will not be getting the information from the patient. Now, going on to the next one, the next P will be the presenting complaint. Presenting complaint is mainly the one reason why the patient is coming to see you. The main reason why I'm here, and we should know the main reason why the patient is here. Otherwise, everything that we're going to be doing, if we go away from that main reason, we are already on the wrong side. I will suggest that you use your Socrates. Okay, I'm sure both of you, I mean, all of you will know now is a Socrates. You know what is Socrates? The sites, the onset, the character, radiation, elevation, and then the time, and anything that reduces the pain and comfort, the severity of the stuff. So and you don't use Socrates just for pain. You can use Socrates even for cough. For cough, for example, you might say, for example, the onset of the cough, you don't do the S, the character of the cough doesn't radiate anywhere. Can tell me anything that aggravates the cough, anything that reduces the cough. Can you tell me the timing, the severity, how this is affecting you? You see, this one for that, you can use it, right? So the PC, define your PC clearly before you enter the room. And then apart from the PC, you go now to the associated features, which are divided into two. The features are divided into two. The positive one that allows you or help you to do the confirmation of whatever you have in your head. And now the negatives, which allow you kind of to do now the exclusion, right? So then from there, we go now to the risk factors. Risk factors is mainly we put the patient in his background. We go to the patient background and we check in the background, past medical history, now family history, social history, which is inclusive of where do you live, whom do you live with, what job do you do, what are your hobbies, if you have, and what the famous SADMA. SADMA stands for smoking, alcohol, drugs, medication, and allergy. Now, that's something, for example, that you do for all this kind of thing, the 3Ps and AR. Now, that is the history taken, right? Once that is done, we go now to the next one, which is the physical examination. Usually in medicine, the physical examination is given to you by the examiner. But be careful here. You will be given only what you specifically asked for. So therefore, you need to be, again, well organized and come to physical examination asking from examiner. Number one, you might say, I want to know the patient general appearance. Of course, I want to know now the vital sign. And of course, I want to know the systemic. I want to do systemic review, but mainly I want to focus on the PC. If it is, for example, abdominal pain, then you focus on abdominal pain, which is abdominal examination, right? And you tell examiner, what are you looking for in the physical examination, the abdominal examination, right? So then from there, you go now to the office test, please. Ask for pregnancy test, or so long as the patient is in reproductive age, you should ask for pregnancy test. So dip the urine, you dip the urine to check whether there's anything happening in the urine, for example. Now, and then now you do your ECG and the peak respiratory flow rates. And of course, you jump now to the diagnosis. The diagnosis, you have the diagnosis and the differential diagnosis. Now, remember, the diagnosis is mainly just the provisional diagnosis, meaning kind of the working diagnosis, what you're thinking in your head at that moment, and then now the differential diagnosis is, okay? Now, so from there, we mount out to management. Management, as I said before, the first thing you do, you tell the patient what is going on, the diagnosis, okay? And then you explain to patient the diagnosis in lay term, and of course, you tell the patient now the implication of that diagnosis, and then you go now to the next one, the initial management, long-term management, then the follow-up. Don't forget now your R's, the review, the reading material, the red flag, and the referral if it is possible. So 4 hours altogether. So that is how you do, for example, for a medicine history taken. Now, if you go to the women health, there's a kind of format that you need to use there. What the format that I suggested is called the 9 P's AR approach. Now, what does that mean? Now, the same thing, just like in medicine, you do the P, meaning where you are, who you are, the task, the professionalism, and the building rapport with the patient, go to the presenting complaint, and then now we go now to the associated features. In the associated features is where, for example, we think about the positive to help us to confirm the diagnosis, negative to exclude the diagnosis, and then now the P's, because she's a female, you go through now the period, the partner, the pill, the pregnancy, the pap smear, and prolapse. Now, for your information, pap smear, you can just say, for example, the CST, the cervical screening tests. Okay, now, and then we go now to risk factors, past medical history, family history, social history, where do you live, whom do you live, the job that you do, the hobby and SADMA, just like what we did, for example, for medicine. And of course, now you go now to the physical examination, same thing like what we did for medicine, it's not different. And of course, now the management, again, the same thing. So the difference is just mainly on the history taken, 9 P's, but 3 P's in medicine. Okay, now, what if the children have, what is the approach? Now, please, I suggest you use the 4 P's. Medicine, 3 P's. We come now here in pediatrics, 4 P's. And in women health, 3 P's. And the 4 P's here are what? The 4 P's is the same thing. For P, the where you, where are you, and then who are you, the task, the professionalism, the rapport. Now, there's something particular, I call it particular, about children. You need to make sure that your child, the mental status is okay. What do I mean mental status? Just simply check now whether the child is active, irritable, or drowsy. Now, please make sure that you check the patient, the child dehydration status, and you check the vitals before you actually embark in taking any history. Because if the child is vitally unstable and you just go ahead and start taking your history, you are not a safe doctor. Okay. Now, from there, now we go now to presenting complaints. The presenting complaint here, the history, the PC, the Socrates, the same thing we do, and then that's the features now. It's the same thing. And of course, now we come now to risk factor. Now it's a bit different here. When it comes to risk factor, we check now the past medical history of this child. The child past medical history is attached to his or her mother. So therefore, past medical history most likely will be P bias. P stands for the pregnancy. B stands for the birth. What happened around birth? Was it a natural delivery or was it assisted delivery? Was there any resuscitation? And then from there, when the child is born now, what about the immunity? Immunization. Immunization is up to date. And then we go now to nutrition. And of course, now we come now to the growth. Ask the mother, are you concerned about anything about the growth? And then do you have any siblings? The child doesn't have any siblings. Of course, we go now the family history, social history of the mother. Okay. If the child is grown up, so you can check now the family history, social history of the mother and the child as well. Now, if the child is still little, then you just check now where do they live? Okay, the mother, where the mother live, or the main caregiver, where does they live? And then now, you check now the whom do they live with, the job and the hobby, and then the SADMA. Now, it's the same thing here. Now we go now to the physical examination, same thing. Physical examination will be the same thing, and then management also the same thing. When we come now to mental health, do we have any format that we use there? Yes, we use 4 P's. 4 P's AI. Just like the way we do for pediatrics, we use 4 P's AI. What are the 4 P's in here? The first P, the same thing here. Where are you? And then of course now, who are you? And then the task given to you: professionalism, rapport, risk, reliability. Okay. Now, so in this case, when we talk about professionalism, are you able to build rapport with the patient? If you're not able to build rapport with the patient, whatever the patient is saying, is it reliable? Is there any risk here? Risk to harm himself or harm people around him or harm the society? You kind of or risk to relapse, right? So in your head, you're thinking, already kind of thinking, all those will appear, for example, in the scenario, okay? And of course, now the particular here will be confidentiality. You need to build confidentiality in the patients, because most patients in mental health, it's a bit difficult for them to build a rapport with you. So if they don't come to a place where they know that you can kind of listen to them properly, they are not going to open up for you, and that is called confidentiality. Now, the presenting complaint now, in this case, you go for the PC, you do your Socrates, but you need to add in your heads. The head is a psychosocial history, right? So head, H stands for home, education, now employment, and activity. Activity, just hobbies, okay? And then drugs, and you can just sneak in there, kind of depression in there, and then the triple S's, sexual, and then, smoke, and then suicidal. Now, then we come now the associated features. Now we do the positive finding and then the somatic features plus foundation. Now, foundation here, what I mean by foundation is that all patients coming to you in the mental health, with mental health issues, they are either having stress, they are anxious, anxiety, they are depressed, depression, they are psychotic, like psychosis, or they having personality disorder. Okay, that's the foundation. So you ask that quickly in your history. And of course, we go now to the risk factors: the past medical history, family history, social history, where do you live, whom do you live with, what kind of job do you do, hobby, and the SADMA, right? And then, of course, now in the physical examination, we go through the same thing again, general appearance. The vital signs in mental health is actually MMSE, mini mental state examination, which assessing the patient's memory and patient cognitive function. Now, that could be done, for example, by asking patient 30 questions. Just 30 questions, it lasts for 5 minutes. And it's assessing the patient memory and cognitive function. Okay, now, the systemic review here, mainly when you're doing physical examination in mental health, is equivalent to MSc, physical examination, okay, in medicine. If you come into mental health, it's equivalent to MSc, Aseptics J, which is something that they will be expecting you again to know how to do it properly. Now, I do have a class that I conduct just for Aseptics J to help you to properly do this mental state examination and to know how to present it. Now, the next one, for example, the diagnosis and differential diagnosis, the reason management. Of course, now you tell the patient, blah, 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 go through all the things. Okay. Okay, now, I'm coming to the end of this video. And I'm sure what is going on in your mind right now is that, my goodness, okay, my goodness, that is what is going on in your head now. You're thinking now, how in the world am I going to be prepared for this exam and successfully clear it? I want to reassure you, and I'm saying this, I'm not just saying this, lightly. I mean it. I want to reassure you that regardless of where you found yourself in, hope is not lost. Okay? Regardless of your story, regardless of where you came from, regardless of how many times you have tried, even if you've never tried, it doesn't matter. Your background doesn't really matter. What matters is the reality. The reality is that this exam, although is challenging, but it is possible to clear the exam. Some people think that you need luck. No. I'm here to tell you. Listen to me. I'm here to tell you that this exam, it is possible to clear it. Okay, it is possible to clear the exam. It is possible to pass the exam successfully. Okay, now, this is what I'm going to be telling you. I'm going to be encouraging you to do. If you've listened to me and then you find yourself in one place or another, you think that, okay, you know what? I think I need help. I need help. I don't think that I'm able to clear this exam based on your presentation. I think I need help. The only thing that I'm going to be suggesting to you is that I've been doing this, helping hundreds, thousands, of IMGs to clear the exam. I've been doing it now for many years. So if you want help, all you need to do is just to email me. Okay, you just email me, or you just jump into my website and you will find out the services that I provide to help IMGs to clear their exam. Okay, you can just email me at kpascal@yahoo.com, or you can just jump into my website and you will find different services that I offer. Now, until then, I'm wishing you all the best for your preparation. I want to repeat again, hope is not lost. You are not hopeless. Please don't let anything stop you from entering your destiny. Now, if you feel like your calling is mainly to serve in the medical field, don't let anything stop you from doing that. Not even this exam, because it is feasible, it is possible to clear the exam, right? So just make sure you don't give up, you stand up, do the needed, the needy, whatever is needed, and I will see you on the other side. Until then, I wish you all the best and see you soon. Bye-bye from now. Bye-bye for now from Sydney.